Welcome to the CREOG modules on caring for transgender and gender nonconforming patients for the obstetrician gynecologist. This module is the second of several modules that will introduce you to the role of the obstetrician gynecologist in providing care for this patient population. These modules were created with the support of the CREOG Empower Award and with the support of the University of Michigan. In this module, we will discuss preventative care for transgender and gender nonconforming patients. As obstetrician gynecologists, we may see transgender men, people who are assigned female at birth, transgender women, people who are assigned male at birth, as well as gender nonconforming or gender non-binary people. For all of these patients, we should address preventative care needs, including vaccinations, STI screening, cancer screening, and screening for metabolic and cardiovascular disease. When considering preventative measures for transgender people, a general principle is to be guided by anatomy and hormonal status. Does your patient have a cervix? They should have regular Pap tests. Do they have a prostate? They should be screened for prostate cancer, according to the regular screening guidelines. There are no differences between vaccine recommendation guidelines for cisgender and transgender people. If a transgender man or gender nonconforming person with a uterus is considering or planning a pregnancy, they should be offered MMR prior to pregnancy. Routine HPV vaccination is recommended by the Centers for Disease Control and Prevention, CDC, and the American College of Obstetricians and Gynecologists, ACOG, regardless of sex, at ages 9 to 26 years. The target age for HPV vaccination is 11 to 12 years, regardless of sex, but the HPV vaccine can be given to all people through 26 years of age. In addition to standard adult immunizations, hepatitis A and B vaccination should be discussed with transgender and gender nonconforming patients. The CDC recommends offering hepatitis A and B vaccines to men who have sex with men. Although this categorization may not fit well for transgender and gender nonconforming people, they may also be at increased risk, and hepatitis A and B vaccination should be considered. For many transmasculine people, transgender men, or non-binary and gender nonconforming people assigned female at birth, genital exams in general, and speculum exams in particular, can be emotionally and physically difficult, at times triggering dysphoria. Be mindful, as in any pelvic exam for any patient, of the possibility that your patient may have a history of sexual abuse or trauma, and that a pelvic exam may be stressful. For people receiving testosterone for masculinization, pelvic exams can also be painful due to vaginal atrophy. Using a small or pediatric speculum and exam gel is usually sufficient to alleviate discomfort. Application of lidocaine gel can also be helpful. Prior vaginal estrogen treatment may also help alleviate discomfort. Under certain circumstances, consideration for an exam under sedation or anesthesia may be warranted. A greater than average proportion of Pap tests will come back inadequate for patients who take testosterone and may require repeat exams. It is a good idea to let your patients know in advance that they may need to come back for a repeat Pap test. Having your patients trust and making sure they're comfortable is more important than them getting a Pap test. Under most circumstances, a pelvic exam with Pap test can be deferred to a follow-up appointment so that you can gain the patient's trust and they can feel prepared for the exam. If a patient is very reluctant to have a pelvic exam, certain information, such as gonorrhea and chlamydia testing, can be sent from the urine. There is no evidence to suggest that transgender men are at increased risk for any gynecological malignancies, including ovarian, tubal, uterine, or breast cancer. For transgender men who have not undergone mastectomy, screening should be done according to the usual recommendations for cisgender women. Following masculinizing chest surgery, some residual breast tissue is usually present. However, it is typically insufficient for mammography screening. While there is no evidence to show the effectiveness of any particular approach, annual chest exam or chest self-awareness can be considered and discussed with patients, and ultrasound or MRI can be used to assess any suspicious or new findings. Data on breast cancer in transgender women is limited. Using extrapolated data, it is recommended to start mammography screening in transgender women every 2 years after at least 5 to 10 years of exposure to estrogen, and after the age of 50, using screening guidelines for cisgender women. It is also useful to know that most transgender women will have a prostate. It is typically not removed in male-to-female bottom surgeries or vulvovaginoplasties. While as obstetrician gynecologists, we may not be familiar with more recent guidelines for prostate cancer screening, as we typically do not see patients with prostates, we can recommend screening according to the regular screening guidelines for prostate cancer. Discussion of sexual health is an important part of a gynecologist's care for their patients. It is also an integral part of assessing for sexual risk, STI screening, and contraceptive counseling. As with all our patients, when discussing sexual health, it is important to be respectful, non-judgmental, and avoid making assumptions. Transgender people may be straight, gay, lesbian, bisexual, or define their sexuality differently. Additionally, sexual practices may vary. A survey of transmasculine individuals noted that top-rated health concerns were desirability, sex drive, sexual assault or coercion, and pregnancy. Keep in mind that terms we are used to using in the context of cisgender people may fall short with transgender patients. For example, if you want to know if a trans man is having receptive vaginal sex, you'll likely need to ask that exact question, instead of only asking if he is having sex with men or women. Some transgender people may use different terminology to speak about their genitalia. You can follow your patient's cues and use the same language they use to describe their anatomy. For example, if a patient talks about their front when referring to their vagina, use the same word. One can also ask patients what terms they are comfortable with you using. A survey of transmasculine individuals reported that the majority, 78%, wanted a provider to ask their preferred language for their body, although a majority, greater than 60%, also preferred that their provider use medical terminology, although this percentage was lower following gender-affirming surgeries. Using gender-neutral language is a good way to open up a non-judgmental, non-assumptive conversation about your patient's sexual partners and practices. For example, what parts do your partner or partners have? How do you use your parts in sex? Do you have any front or vaginal penetration with a penis, fingers, or toys? While testosterone levels within the male range usually suppress menstruation, there is insufficient data currently regarding its suppression of ovulation. Testosterone use is not considered adequate contraception for transgender men who have insertive vaginal intercourse with anyone who produces sperm. Additionally, testosterone is a teratogen and can cause reduced birth weight and masculinization of a developing female fetus. It is hence recommended that transgender men who have not had a hysterectomy and are not trying to get pregnant either use barrier contraception or an alternative contraceptive method such as progesterone-based contraception that will not interfere with masculinization, such as progesterone-only pills or an LNG IUD. We will learn more about transgender men and pregnancy in Module 4. The CDC comments on transgender men and women with regard to sexually transmitted diseases, but with few specific screening recommendations or intervals. Transgender women, particularly Black transgender women, bear a disproportionate burden of HIV, with HIV prevalence estimates of 22 to 28% for all transgender women and 56% for Black transgender women. Based on anatomy and sexual behaviors of transgender and gender nonconforming people, clinicians should assess STI and HIV-related risks. For individuals at high risk, who have multiple partners, condomless sex, transactional sex, or sex while intoxicated, screening is recommended every 3 months. Additionally, for HIV-negative individuals with elevated risk for HIV acquisition, pre-exposure prophylaxis, or PrEP, should be discussed. Although not specific to the transgender population, the CDC screening recommendations for men who have sex with men include at least annually HIV serology, syphilis serology, urine test, nucleic acid amplification test or NAT for urethral infection if insertive intercourse, rectal test, rectal specimen NAT if receptive anal intercourse for gonorrhea and chlamydia, pharyngeal specimen test, NAT, if receptive oral intercourse for gonorrhea only, as well as HCV screening for HIV-positive individuals. Given the differing effects of steroid hormones on the risk for cardiovascular disease, one should take both past and current exposure to steroid hormones, as well as other risk factors, such as family history and personal medical history, into account when making decisions regarding screening for cardiovascular disease. When using cardiovascular risk calculators, consider using natal sex, affirmed gender, or an average risk, depending on the length of time since initiation of hormone therapy. Additionally, data about the effects of hormones on lipids and blood pressure in transgender people is limited. Estrogen exposure in transgender women has been associated with increased HDL, decreased LDL, increased weight, increased blood pressure, and increased markers of insulin resistance. Evidence regarding cardiovascular risk for transgender women compared to cisgender men is mixed, whereas evidence more consistently suggests unchanged cardiovascular risk among transgender men compared to cisgender women. For transgender women with elevated risk for cardiovascular thromboembolic disease, transdermal estrogen administration may be preferable to oral, sublingual, or intramuscular administration. Similarly, given some data suggesting an increase in insulin resistance, secondary to testosterone exposure, screening for diabetes may be warranted earlier in transgender men receiving testosterone. Other cardiovascular-related risks related to testosterone may include polycythemia, elevated LDL and decreased HDL, elevated total cholesterol and triglycerides, and possible hypertension. Mixed data exist regarding bone health, but bone mineral density is likely affected in both transgender women and men by the length of exposure to testosterone and estrogen. Use an individualized approach and take into account all other risk factors, paying particular attention to prolonged periods of hypogonadism. Additional risk factors include race, age, BMI, family and personal history, smoking, alcohol intake, chronic corticosteroid use, and chronic risk conditions such as rheumatoid arthritis, HIV, immobility, and vitamin D deficiency. In summary, many preventative services are the same in transgender and gender nonconforming individuals as compared to cisgender individuals. Screening should be based on anatomy, hormonal status, and other personal risk factors such as behavior and family history. Thank you for viewing Module 2 about preventative care for transgender and gender nonconforming patients.